Hi everybody. It's the we're a bit close. It's the time and the place here. And we've got a comment. We've got a comment before we even started. Look at that. That is how we start this show, my friends. A comment before we started. So Gemma, that's awesome. Thank you. Oh, not good it says, but anyway. Thank you for that. Gemma Khan, hello, nice to see you here today. I've got a few questions going on, and Gemma's straight in there. Didn't know Nagor offered a warranty. I've had CC for 3 years now. Not good. Oh. Yes, Nagor do offer a warranty, Gemma, and I will talk about that. That's one of the questions. But having said they offer a warranty, it is good. Well, it's not good that you've had capsular contracture, but the good thing is that the Nagor warranty covers capsular contracture, and I'll tell you exactly what it covers. But the other thing I would say is that anyone who's got a capsular contracture who comes to see me, and something I've got to say, particularly for these questions I got today, because I've got some questions today, which really I've got to say, these are all the things I'm saying is my opinion. And all doctors have different opinions, particularly in plastic surgery. There's not, stuff that's cut and dried. So don't take it, don't take it as read. Don't take it as fact. It's just my opinion. So yeah, so for capsular contracture, I always say to people, leave it as long as you can, because the longer you leave it, the better. Because if you do something about it, well, unless you're going to remove the implants. If you're going to remove the implants, then fine, you can remove the implants. But if you can remove the implants and replace them with other implants, those implants are going to start to develop a capsular contracture. And the other thing is they're going to start to develop a capsular contracture quicker than the first lot, because when you do a capsulectomy and change of implants, it's a much bigger operation than when you just put the implants in to start off with. And so it creates more scar tissue. And so that is what capsule contracture is. It's scar tissue. So the capsule comes set quicker after the second operation than it does the first. And so if you keep on saying, and so, don't I? So yeah, leave it as long as possible, because you don't want a clock ticking on the second set of implants. And so the fact that you've had it for 3 years is not it's not a bad thing that you've left it, because I would tell you, if you came to see me anyway, that the longer you leave it, the better. But I will tell you also about what the warranty for Nagor is. And I'm sorry if you didn't know what the warranty for Nagor was. So we're going to kick off with number one, question number one, which I'm going to show on screen right here. Right here. What serial excision? Why do you have to wait a minimum of 3 months between excisions? Good, lot of good questions tonight. I've got to say that's one of them. That is a good question. So people having serial excisions are people who've got big things. Usually, to be honest with you, it's tattoos, but also things like moles. If someone's got a very big mole, if someone's got like a big skin graft, or something like that they want to have excised, a big thing that can't be excised in one go. You can excise it in several goes. So what that means is you excise as much as you can in the first go, obviously, and when you've finished excising it, so you've got, like, say, a big tattoo, you excise as much of it you can, and then you're left with a scar with still a big tattoo on either side. Now, when you finish that operation, when you finish that excision, it is really tight. There's no way you could have taken any more out, otherwise you would have taken more out. It's really, really tight. But then as you leave it, the skin gives. That's an attribute of the skin. If you put the skin under tension, more skin grows. That's why people need a tummy tuck. That's why people need a breast lift, because when you put the skin under tension by being pregnant or putting on weight, you're stretching the skin, and it's a gradual thing. If you got to pay a person and try to put a term baby inside their tummy, it would never fit, because it's too tight. But if the baby grows over 9 months, gradually stretching, as it puts the skin under tension, more skin grows. So we use that attribute of the skin to our advantage when we do a serial excision. So we close it really tight, tight as anything. You got to leave it 3 months, because if you leave it less than 3 months and you try and go back, it'll be too tight. If you go back the next day and try and take more out, forget it. You'll take the stitches out, the thing will ping open. You probably won't be able to close it again. It'll be really, really tight. So you have to get it healed and get the scar softened and get the tissues softened. And as they soften, because you put them under stretch, more skin will grow and it won't be so tight. So the first day you have it, you think, oh my Lord, he's taken too much out there. Really tight that is. Oh God, that's uncomfortable. Next day, actually, it's not so uncomfortable. And then 3 months later, it's not uncomfortable at all. It feels normal and the skin feels nice and soft and moves nicely. So you can go back and do it again. It's a minimum of 3 months, because you have to let those tissues soften and settle. Because if you try and do it before 3 months, they will be too tight and it'll be difficult. And it's horrible doing surgery before 3 months. Everything's woody and doesn't move and hard, and you just can't get as much out. It's a false economy for a serial excision, because you won't be able to get hardly anything out if you try and do it in less than 3 months. And the longer you leave it, the better. Obviously, people want to have it finished, this sort of treatment, so they want it as soon as possible. If you can leave it 6 months, if you can leave it a year, you'll be able to get even more out. But you might say, look, I want to get it done, I don't want to leave it a year. So it's a balance. So that's that question. Let's answer that. Do I need to come off the contraceptive pill? Had read that somewhere. You might have read that somewhere, because some people say that you should do that. And again, my view only, and it's really up to your surgeon as to whether you do that, because it is, you're absolutely right. Some people will tell you to come off the contraceptive pill if you're having surgery. The reason they do that is because a contraceptive pill will increase the risk of clotting, and so you worry about DVT, which can form clots in your legs, which can flow off into your lungs. And then it's a PE if it goes to your lungs. It's a very bad thing that is a complication of any surgery, of any period of immobility. So it's increasing your risk of DVT if you're in the contraceptive pill. Personally, I don't tend to tell people to come off it for a couple of reasons. Number one reason is that the surgery is not normally that long. If you're having a massive, massive long operation with a high risk of DVT, then maybe you would consider it more like 6, 7, 8 hour surgery. Most surgery that we do is between 1 and 3 hours. So, you know, it's not that long. The other thing is we do lots of things to reduce the risk of DVT, including early mobilization. You're not going to be bedbound for a long period after surgery. Again, most of the surgery will try and get you out of bed the first day. You might not be like massively mobile, but we try and get you out of bed the first day. And the other thing is, if you are going to say to someone you've got to stop the contraceptive pill, you should stop it about 6 weeks before. And then obviously you've got to use alternative forms of contraceptive. So we have to counsel you about that if someone's going to say to you to stop the contraceptive pill, because you don't want unwanted pregnancies and all the complications associated with that. So it's not something you can say lightly. You have to counsel people about using alternative forms of contraceptive if you're going to advise people to come off the contraceptive pill. But as I say, we tend not to, but it's a valid thing. As a, you know, a lot of this stuff is opinion, and if someone tells you that you should be off the contraceptive pill, that's why they're saying it, because of your risk of DVT. But we tend not to, for reasons stated above. When you say you can't exercise for 4 to 6 weeks, is this just upper body? Can I still do exercise but avoid the chest, arm, shoulder areas? If so, how soon? This is a person who is asking about breast augmentation, to put it into context. So it's you know, obviously it's an upper body thing. The breast obviously is an upper body thing. In case you haven't noticed, it's an upper body organ. It's an organ of the upper body. So it is correct. It is just upper body. Yes. Now, what I normally say to people, and a lot of this is common sense isn't the right word, because you don't know, because you haven't had the surgery, but it's a lot of it. I don't have to tell you. You won't feel like doing much upper body exercise in the first couple of weeks anyway. You won't feel like doing much exercise of any of your body in the first week and probably 2 weeks. So whatever I say, even I say, oh yeah, you can get back to the gym straight away, you'll be like, oh, flipping heck, it's really uncomfortable, sore, and all that sort of stuff. So I normally say the first couple of weeks you probably won't feel like doing anything at all. After, and you don't really want to get hot and sweaty and put tension on the wounds and all that sort of stuff. So I wouldn't do any exercise upper or lower body for the first couple of weeks. After 2 weeks, again, ballpark figures, not same for everybody, but ballpark 2 weeks, you can start doing lower body, and that means low impact. So not jogging. Jogging's boom, boom, boom. So you want to be doing like the exercise bike, the stepper, but not using your arms, stuff like that, after 2 weeks. And then the 4 to 6 week thing is your upper body, because if you move your upper body, every time you're moving your upper body, you're moving the muscle. So if you're moving the muscle, whether the implant's above or below the muscle, it's sort of next to the muscle, whichever side of the muscle it's on, it's next to the muscle. So every time you're doing that, you're like making it swell, basically. And if you go to it too soon, I know what you well, I don't know what you like, but I know what people are like. Sometimes they're like, oh, I'm going to get back to the gym because I've got to push it. Come on, guys, let's go, go, go. It's a false economy, because you make it swell and it takes longer to settle, and you'd have been better off not not going back too soon. So yeah, 4 to 6 weeks. And then what I say to people is listen to your body. Again, these are ballpark figures. Some people feel great at 4 weeks. They do a bit of exercise, it's fine, carry on, everyone's happy. Some people at 4 weeks, still a bit sore, do a bit of exercise, it swells up a bit. Well, back off then. Don't think I've said you can go back at 4 weeks, so I'm going to go for it. Sorry. Just listen to your body. Listen to your body. Your body will tell you. Listen to your body and me as well, but listen to your body mainly, really. Debbie straight in. Debbie's got in there. Good evening, Jonathan. Why are some TT scars higher than others? Is there a specific reason to have it higher or lower, or is it PS preference or patient preference? Listen, Debbie, I'll tell you what, patient preference and PS preference as well is to have it as low as possible, isn't it? Pretty much, everyone wants it low. So no one wants a high tummy tuck scar, and it's something that we worry about, a high tummy tuck scar. So but I can definitely answer your question on why some are higher than others. It depends on how much skin laxity there is, because when you are doing the surgery, you cut out an ellipse of skin from the lower abdomen and then from above the belly button, and you pull the stuff from the upper abdomen down to meet the lower abdomen. And the more lax the skin is, the more you have to undermine it and all that sort of stuff. But the more skin laxity there is, the more it's going to come down and just meet the lower scar and be a low scar, which is what we want. We always want a low scar. So the paradox of this is the less skin laxity there is, the tighter the skin is, the harder it is to pull it down and get it to stay down low, because it wants to spring back up. So the more elasticity you've got, the higher the scar will be. So this is a paradox, because people who haven't got much excess skin in their tummy, who've maybe had one child, have still got good quality skin and good quality elasticity of their skin, which is a good thing, but actually they're more likely to get the scar pulling up. Oh God, sorry, getting carried away there. Oh, I don't want to show. Oh no, I'm showing my bookcase. God, it looks good bad from that angle. It's not really that bad, guys. Honestly, it's not. The bookcase is much more ordered than that. I don't know if you noticed, I'm trying a different angle today. Oh, you can still see it, can you? Oh, you can see it more. Oh, I'm trying a different angle. I shouldn't be trying. Oh dear. And I've got the door, and if someone comes in. Okay, anyway. Let's stick with the program, guys. Come on, stick with the program. So the paradox is that if you've had loads of children, or if you've lost huge amount of weight and you've got really lax skin, you'll be able to get the scar lower than if you're really taut and tight and you've had one child and you just got a little bit of tight, a little bit of fullness there, because there you worry the skin's going to pull up higher. So actually, the sort of weird thing is that as someone who's actually quite trim and got good quality skin, and has only got a bit of fullness in their tummy because they've had one, two, or maybe just a few children, are at risk of getting a higher scar than someone who's hadn't had a massive weight loss, or had several children, or had multiparous, what is it, twins and things, like that. So that's the sort of person who is more likely to have a lower scar. And then so then we get into the situation when people who have got tightness, then we've got a situation, what do we do? Do we do a mini tummy tuck, or do we make a little T incision, a little T extension? They could keep a low scar, but make a little vertical extension on that, which is a discussion that we should have with you in the clinic if you're in that category of being, got quite good elasticity of your skin. Have I made that clear? I don't know, but I gave it a go. But so yeah, it's basically everyone's trying to make it as low as possible, Debbie, and it just depends on the amount of laxity as to how low you can get it. How low can you go? Zoe is saying good evening multiple times. Good evening, Zoe. Sonia has come in. I've just been diagnosed with borderline ovarian tumor and it has gone to the fatty apron. I have chose not to have surgery. Can I still have a tummy tuck? I really want to have it done. Advice would be great. Sonia, you need to, or you don't need to do anything, but we would probably um, talk to your gynecologist because I don't know what you mean by the fact that your tumor, ovarian tumor, which is intra-abdominal, inside your abdomen, um, has gone to the fatty apron. I'm not sure what that. Oh, very informative. Oh dear, you haven't heard me yet, Sonia. I don't know if I'm being very informative. I'm not sure what that means going to the fatty apron because oh, I look pale. I'm pale when I go down there. When it goes to the fatty apron, the thing that is removed when you do a tummy tuck is all outside the abdominal wall. If you can imagine, I don't know if you know what a cross section of a body looks like. Is that what people know? Do people know what that looks like? But anyway, you've got skin, then you've got fat, then you've got quite a tight layer of tissue called fascia, then muscles, then you've got some layers of muscles, and then you've got your abdominal contents. So your bowel, your stomach, your spleen, your liver, and your ovaries are in with all that stuff. It's all in with your liver and your spleen and all that sort of stuff. It's inside your abdomen. So to get to your ovaries, you have to cut through the skin, you have to cut through the fat, and then you get down to the muscle. When we do plastic surgery, when we do tummy tucks, we stop at the muscle. We don't touch the abdominal wall. We sometimes repair the muscles, but that's different. We don't go through the muscles. If you want to get to your ovaries, you have to go through the muscles into the abdominal cavity. So it doesn't really match that you're saying you've got a borderline ovarian tumor, which suggests that it's not that bad. And then you're saying it's gone to the fatty apron. I'm thinking, what does that mean? That ovarian tumor has metastasized? Has it spread? If it has spread to the skin of your abdomen, that's quite that's quite extensive and quite um, sort of end stage. I don't think that's what you mean. I don't think you've got tumor inside your fatty apron. Um, but if you did have tumor in the fatty apron area, I think I would say I would not have a tummy tuck done if there was actually tumor outside your abdominal wall and in that fatty tissue. But I don't. That would be a really odd thing. But the bottom line is, Sonia, we would speak to your gynecologist, or in fact, probably better because we charge for consultations and stuff. Is you could speak to your gynecologist because just say to your gynecologist, or if you're or whoever's looking after you, if it's your GP or your um, gynecologist, just say to them, look, I'm thinking of having a tummy tuck. Do you think that will affect it with this ovarian tumor thing? And if you did come and see us, we'd write to them and say, is that okay? Yes, I know, so it really won't affect it. Yeah, I don't think it will affect it. If it if you can actually feel tumor within the fatty apron, then I would be a bit worried about that. But if it's a borderline ovarian thing, it should be miles away from where you're having your tummy tuck, to be honest with you. Your ovaries are miles away. So people who've got ovarian problems, uterine problems, is not going to have any effect on having the surgery. Oh, omentum. Omentum. Okay, it's spread fatty apron is the omentum. So omentum is fat inside intra-abdominal fat. So it's inside that where the stomach and the liver and the spleen and the pancreas and all that is. Omentum is inside the fat, inside the abdomen. So that's different. That's not, fatty apron tends to be the bit that we remove when we do a tummy tuck, which is the subcutaneous fat. Omentum is intra-abdominal fat, is totally different, is miles away. We don't see any omentum when we do the surgery, and it's different. So yes, that's fine. The omentum would not be touched during a tummy tuck. Um, as I say, momentum is all around your stomach and your bowels and what have you. But nevertheless, I think we would probably just copy correspondence to your gynecologist and make sure your gynecologist was comfortable with the plan. But yeah, momentum's far away. But thank you, Sonia. That's a good question. Where am I up to these questions here? So we've done that one. Done that one. No, Sonia, thank you. Thank you. That was a good question. And I hope I was sort of okay with the answer there because it's a little bit a little bit of a tricky situation. It's a little bit of an unusual situation, but yeah, the bottom line is when someone has a problem with another part of their body, whether it be their heart or their brain, you know, if they've got epilepsy or if they've got, I don't know, diabetes or something like that, or any sort of problem, we would normally liaise with the doctor who's looking after that other thing, just to make sure they're okay with it and there's nothing they need to maximize before they have the surgery. So it's just good practice to talk to the other doctors just to make sure that they think, oh well, wait, you might want to do this, you might want to up the dose of this or reduce the dose of that. So that's as a general principle, and I think that's what most people do. Thank you, Sonia. So here we get to the question which we were all waiting for. Were we? Or some of us were anyway. About the Nagor warranty, because Gemma's got Nagor implants in and didn't realise that there was a warranty. So, oh, blimey, right. Sorry. So what Nagor do warranty? Oh dear, what warranty do Nagor offer? Sorry, I've spun it around. So would you be willing to do? It's hard to say on this sort of thing, Sonia. Probably number one, we'd need to see you, Sonia. But if you've got a problem with your ovary and with your omentum, that will not be touched with the time of a tummy tuck. So in print, and I'll give you an answer in principle. So in principle, that will be fine. But we would talk to, where's the camera? We would talk to your gynecologist. Sonia, I'm just really running the clinic now, and I'm just working with the doctors we've got there. So if you wanted to come and see us, it's Kuram Khan is doing this sort of stuff. He's a plastic surgeon. He's a colleague of mine, and he's doing all the surgery. So you'd be welcome to come and see Kuram. I'm always around. I'm there every day. But you'd be welcome to come and see Kuram. It would be lovely to see you, and we would definitely talk about what's involved and these issues. And as I say, if you did come and see us, we would write to your GP and also to your gynecologist to make sure that everything was kosher. Debbie's back in. Debbie, back in. Look at you. I've heard that some PS do not use original belly button during TT. How do they make a new one if the skin is all stretched and marked? And have you had many that have died? Oh, Debbie. Debbie. Ask me questions like that. Yes, so PS plastic surgeon, by the way, everyone, for these abbreviations, TT tummy tuck. So you're absolutely right. I mean, to be honest with you, Debbie, very rare. There's a guy who talks a lot. He's I think he's from Colombia, who shows really nice results from his tummy tucks. Alfredo Hoyos is his name, and he's often talking about tummy tucks, and he routinely removes the belly button and makes a new one, routinely, like for everybody. That's pretty rare, to be honest with you. Most of us wouldn't do that. We do make new belly buttons in people who have been born with congenital abnormalities of their abdomen, who haven't got belly buttons, or of course if the belly button dies, if there's a problem, you can make a new belly button. So it's pretty rare. How do you make a new one if the skin is all stretched and marked? Well, you make a new one in the same piece of skin that's there, and all a belly button is a scar. It's just a scar from where the umbilical stalk was. So all you do is you basically have to make the skin puckered down into the rectus muscle, onto that muscle layer. So you take away the fat and you move some flaps, and you just use the skin that's there. So if the skin is stretched and marked, so if it's stretched, that's fine. But if it's marked, if you've got stretch marks, you'll still have stretch marks on the skin, but you would have if you'd use your original belly button. But yeah, you just basically take some fat away and then anchor the skin down onto the abdominal wall to create a dent, because that's what a belly button is. It's a dent. It's a scar from the umbilical stalk. And have you had many that died? No, Debbie, I haven't had many that died. I have had one that's died, though, which was many years ago, several years ago, and so it can happen. But thank you for asking. So yeah, I have had one. I have had one die, and I have been involved with a couple of others that have died. It haven't been my cases. I've been sort of helping out with them, so I have helped out in other surgeons' cases where they've died. but that's sort of after the fact sort of thing. But personally, it has happened to me, unfortunately, Debbie. But to be honest with you, it's not as bad as you. Well, it's pretty bad to be honest with you, but it's not as bad as you might think because it sounds terrible. Because you sounds like necrosis. Oh my god, umbilical necrosis and things. It's a terrible word that. But actually, you can often pull it back, and there are sort of, I guess, there are worse complications, but that's a pretty bad one. But yeah, it's out there, and you have to be able to deal with it, and yeah, you can deal with it, and you can fix it. We can fix it. We can rebuild you. Fiona, I just tuned in our Nagor most popular implants as I have them. Sorry if I've missed Nagor conversation. Well, you haven't missed. We're just about to talk about Nagor, Fiona. Are they the most popular implants? Oh, that's a difficult question. They're very well silicone. The basically there's different types of implants: silicone, polyurethane, saline. Saline aren't popular at all. Polyurethane are pretty popular, but out of the lot, then silicone are the most popular implants out of those sort of varieties, those types. I don't think Nagor are the most popular. They're quite popular in the UK, Nagor. Worldwide, they're up there. They're one of the top ones. America's obviously a huge market, and America have the FDA that a lot of people talk about, which is the Food and Drug Administration. Oh, it's that one. And there's only a couple of implants that are made that are approved for the FDA approval, which are Allergan, Mentor, and Sientra. We don't have Sientra in this country, but we do have Allergan or Mentor. So worldwide, I'm sure Allergan and Mentor are bigger companies than Nagor, and they probably sell more implants. I don't know all the figures, but Nagor are up there. They are made in the Nagor are made in the UK. I like Nagor, but at the same time, I don't push them on anybody. Anyone who comes and says, "Oh, I've heard these are the best implants," I'm like, well, there might be good implants, but there's no one best. And if someone wants Allergan or Nagor or Mentor or whatever make, or Polytech or whatever make, then they can have that, as long as the hospital, like we talked about last week, as long as the hospital have it on their sort of formulary sort of thing, as the ones that they can order type thing. But yeah, so I'm not sure if they're the most popular. They're very popular in the UK, and their silicone implants are certainly the most popular. But I don't think Nagor is number one. I think they're all pretty. There's a few big companies, and Nagor is certainly one of them. And that leads me, Fiona, into my question of Nagor warranties, because Gemma was asking about this because she has got Nagor implants and didn't know about the warranty. So yes, so this gets a bit confusing, and you've got to be careful in terms of. Sorry, that I don't know if I need a collarbone there or what. I guess it's like that all day, isn't it? And I just don't know. I'm just walking around like that. But now I see myself, and I'm thinking, why is that collar slouching like that? Oh, shall I do my button up? Does that just look weird? I don't know. It's quite smart. How's that? Probably need a tie, really, don't I? Anyway, sorry, I should have sorted that out before. So the Nagor warranty is a good warranty, I think. So the one thing you've got to be careful of is what is covered. And this got another question about this in a minute, but specifically with implants, the implants have a warranty, they have a guarantee. The Nagor, and they're all different, they're all subtly different. They pretty much all of them, well, some companies have a sort of premium range and a lower range. Well, I say some companies, I'm thinking about Allergan really. Allergan have a CUI range and a Natrel range. CUI is the sort of budget, I suppose, and the Natrel is the premium range. Other companies like Mentor and Nagor just have one, which is equivalent to the Natrel, equivalent to the premium range of the Allergan, and all the sort of premium range implants. Well, most of them anyway. I shouldn't say all because I don't know for sure, but most of them will have a lifetime warranty, and that'll be the sort of headline: lifetime warranty. And you're like, oh, fantastic! Oh, thank goodness for that, covered for life. Happy days. But you've got to think exactly what is covered. What do you mean lifetime warranty? What's covered in the lifetime warranty? Because it's different with all of them. So in Nagor, what is covered is rupture and capsular contracture. Those are the two big things that's going to happen, several years after surgery: rupture and capsular contracture. Now, there's a few issues you've got to think of, because it is different with different implants, because some will cover, they pretty much will all cover rupture, really. The CUI ones, which are the cheaper ones in Allergan, only cover you rupture for 10 years, but the Inspira, the Natrel cover you lifetime. Mentor, I think, is lifetime. Nagor's lifetime. They're all lifetime for rupture. They're pretty much all lifetime for rupture. So the headline will say lifetime warranty, but it might be just lifetime warranty for rupture. So Nagor cover you lifetime warranty for rupture and capsular contracture, which is good. And out of the two, I would say capsular contracture is going to be more likely the reason for having them changed than rupture. But then the other nuances of the warranty you've got to look out for is what do they offer in terms of sizes. So some will only give you one implant, but obviously if you've got a rupture or a capsular contracture on one side, which you may well have, just a capsular contracture on one side, you might want to change both. So some will only offer one, some will offer both. Nagor offer both, so you can have the other one changed as well. And some will be limited into what size you can have. Some will say you've got to have the same size, or you can just move one size sort of up or down. I have to look at the Nagor booklet and all that sort of stuff, and we can send you all the details of the Nagor warranty, but I'm pretty sure the Nagor will allow you to have any size. So you can change the size, you can change the profile, and they will offer both a replacement of both and the change of size. So it's pretty good, but it's just the implants they're going to give you. You still have to pay the hospital costs. So, that's something to be aware of, that some of them will give you money towards the hospital costs, but they don't cover capsular contracture sort of thing. So it swings and roundabouts with all the different warranties. So it's really worth having a look at them all. But the Nagor one just will replace the implants, will replace both implants, will replace different size, different shape, but they won't give you any money towards the hospital costs. So it's still going to be an expensive operation, because a capsulectomy and change of implants is an expensive operation. So that is the Nagor warranty, and it's a very good question that not enough people ask, to be honest with you. We've got booklets and brochures about all the warranties of the different implants, and they're all available online, actually. You probably get them on a PDF online, but it's something that people don't, they just hear the headline, oh, lifetime warranty, I'm covered. Well, we'll get a new implant, but you have to sort of pay for all the hospital costs, which is a lot, to be honest, for a capsulectomy. And this is also a linked question. Nice one. What covers the cost? Sorry, who covers the cost if things go wrong? Very reasonable question. Okay, so the hospitals will cover you for revision surgery for a amount of time. Again, you have to check with the hospital you're working at. I burnt my chicken by watching you. What? Debbie, I can't be held liable for the chicken. Okay, I should have a disclaimer along the bottom saying I cannot be held liable for anything caused by owners who are irresponsible with their cooking. So I'm sorry to hear that, Debbie, but it'll be nice and crispy. So who covers the cost if things go wrong? This is a good question. And so all the hospital, and again, check with the hospital you're working at. We work at two hospitals, BMI and Spire are the two sort of big companies. BMI is the Priory and Spire is the Parkway, but they're, BMI and Spire are big sort of private hospital companies. And they've got hospitals all over the country. And they cover you for revisions. So they cover you for 6 months if it's the BMI and 12 months if it's the Spire. They all cover you for 30 days for complications. So said this a bit in the wrong way. Oh dear. I should have started with a 30-day thing. So basically, who cover, right? Okay, start again. Who covers the cost if things go wrong? Okay, good question. So what happens is all the hospitals will cover you for 30 days for complications. So complications means hematoma, blood collecting inside, an infection. What are the complications? The wound opening up. Something bad happening in the first 30 days of surgery. So that is covered by the hospital. You don't have to pay if you need to go back to theatre, if you need to have a scan, if you need to go to intensive care, perish the thought, if you get heart problems and you have to go to intensive care, and anything that happens, basically, you don't have to pay if you get a complication. That's a complication. If you get a problem, a complication, first 30 days, that's covered. After 30 days, then you're looking more into things what you call revisions. Revisions mean you've all healed up and all that sort of stuff, but one's a bit high or a bit low, or doesn't, it just doesn't look quite right, or you've got a bump at the scar, dog ear, or it's just not sure about that. It just doesn't, one's they're too wide, or they're too close, or they're too whatever. So then we get all the one nipples. Anyway, whatever. Could go on all night, but you get the gist. So that's a revision. So that is where they differ. So some hospitals cover you 6 months, some cover you for a year, and there'll be others who do different things. So BMI do 6 months, Spire do a year. To be honest with you, most things are there at 6 months. I wish they did longer than 6 months. Personally, we've been looking at it because sometimes things settle, but people often think, "Oh, I better get it done within 6 months," because they can be reasonable. So we can say to them, "Look, this is one's a bit bigger than the other, but I think it's just a bit of swelling. Can we just leave it another few months, and see how it goes?" So if we talk to hospitals like that, they'll often be reasonable about it. But in general terms, most things are sort of visible by then, and so yeah, so anything like that in the first 6 or 12 months is covered. Again, hospital costs, anaesthetist, surgery costs, you don't have to pay anything. It's bad enough you have a problem, you don't have to pay anything. So that's who covers the cost if things go wrong. After 6 to 12 months, then it's less so things going wrong as something else happening. And as I say, the common thing with breast implants is a rupture or a capsular contracture. If you're having a tummy tuck, it's probably going to be something like you're putting on weight. If you put on weight, the skin stretches, particularly if you put on weight and lose weight. I can't think of what could go wrong later after 6 or 12 months, but then you have to pay. Now, we don't charge consultations to come and see us, but you have to pay for surgery after the 6 to 12 months. So yeah, so you're sort of covered for the first 6 to 12 months, and then after that you have to pay if you need more surgery. If you just want to come to the clinic for a checkup and you're worried if you've got a bit of this or bit of that, you can come for the checkup. The other thing I wanted to say, what did I want to say? What was the other thing I wanted to say? Who covers the cost? Oh yes, the very important thing is the thing that is covered is two things. The first thing, the thing that is covered is if things go wrong. So if things don't turn out the way we use the royal we, it is sort of based on the surgeon, how we hoped it would turn out. If they just turn out, if they're just too big or they're just too small, or if the cosmetic result is fine, but you don't like it. So this is, I'm talking really about breast implants really here. If you think beforehand you're deciding between the 250s and the 350s, and you have the 250s and you think, well, actually, you know what, I wish I'd got the 350s, you're like, well, then you have to pay. So cosmetic dissatisfaction in terms of the fact that they look fine but they're just too small or too big, that is not covered. So that's why we say to people, come back as often as you want, because you've got to be absolutely sure with the implant choice, because that is not covered. If they're too wide or they're too high, or one's up and one's down or something like that, that is covered. That is a complication. But the fact that they look fine but you think they should be bigger or smaller is not a complication. So that's something which we're keen for you to come back and go over things again. So I hope that's covered that. So Debbie's back in. Look at this, Debbie. God, you're on fire tonight. If a patient needed to go to ITU, where do you use? Do you have ITU facilities? Good question, Debbie. You got to think about what you mean by ITU. ITU is a specific thing, and people talk about ITU. ITU really is sort of 24-hour one-to-one care, and there's not many private hospitals in the country which have a fully staffed ITU. To be honest with you, they don't usually need it, and certainly for the stuff that we do, we don't need it. We are lucky that the Priory, which is in the Edgbaston, does have a 24-hour anesthetic covered ITU. So the Priory, they do like open heart surgery, major back operations. They do major surgery there. So they're one of the few private hospitals in the country with an ITU. Parkway hasn't got an ITU. It has an HTU, a high dependency unit, where you are taken off and you are sort of nursed separately, which, to be honest with you, for plastic surgery is fine, and you can still do big operations. They still do quite big surgery in Parkway. And for anything that we would come across, an HTU would be fine. But if you're talking about a pure ITU, the Priory is the place to go in Birmingham. And some people are attracted by that and think, actually, you know what, I want to go to the Priory because I want them to have an ITU, and I totally understand that. And it's all about having peace of mind, and that's fine. I'm fine operating at Parkway. I've got no problem operating at Parkway. I operated there yesterday, so I operate there all the time. But you know, if you think, well, what if an ITU? Well, yeah, ITU is in the Priory. And if you had a patient who you thought might need ITU, you might think, oh, hold on a minute, we should have a Priory. But again, you should be thinking, should you be doing surgery if you think preoperatively they might need ITU? But yeah, Priory's got great facilities in those terms. But as I say, Parkway's got HTU and can deal with any problems that will come across from the sort of surgery that we do. So, good question, Debbie. Go back to your chicken and see if you can get. Let's see if we can get another one out of you, Debbie, tonight. Huh? Do you think you're up for another one? Get another question out. See how we get on. Are most people? This is a good one, isn't it? Are most people pleased after a BBA, bilateral breast augmentation? Are we? Are there many regrets in patients having this procedure? God, got a bit of a downer tonight, haven't we? Got a tough crowd tonight, I'll tell you. Jeez. Yes, yeah, most people are pleased after a BBA. It's a huge patient satisfaction, huge positive patient satisfaction. The first point I make is often to start off with, it's an emotional time. That's why if you're having a divorce or if you're going through a tough time at the moment, you think, oh God, I'm having a divorce and my partner's left me and I'm moving house and it's all tough and I'm going to treat myself to a breast augmentation. I'll be like, I wouldn't do that because it is quite traumatic when you first have it. So saying there are the many regrets, long term, no. Short term, yes. Short term, you're like, oh my God, what have I done? They're so big. This one's swollen. This one's red. This scar's not good. The nipples are asymmetrical. Look at all these terrible things. It's not what I expected it to be. He said he was going to make it natural, and look, they're not natural at all. And all this sort of thing when you first have it done. That's why if you're going through an emotional time already and you're having, stuff happening in your life that's stressful and you think you're going to treat yourself, I would not do that. Do it when your things in your life are sorted and you can afford to be emotionally stable, sort of thing, to go through with it, because it is quite an emotional event. That's why we have cosmetic counseling and things for people, because it is quite an emotional event. So so short term, yes, there's all sorts of roller coaster emotions. Long term, very, very rare to have people be upset and have regrets. um, I have got one that has stuck in my mind. um, full disclosure, I told you about the belly button that I lost. um, I've got a patient who, it's probably 10 years now, 10 years ago, and I could talk at length about it because it stayed with me. But anyway, she's very unhappy because the implants were too big. And that has sort of stayed with me because I think you've got to be careful. There's a line where people want to go bigger, want to go bigger, want to go bigger. And people always say, oh, I just choose between two, go for the bigger one. Everyone who says, I wish I'd gone bigger, wish I'd gone bigger, there's a line. And it's hard to know where that line is. But once you pass that line and you go too big, people are unhappy. When you're the other side of the line, people are happy but wish they'd gone a bit bigger. But once you go past it and you go too big and people have got implants that are too big, then that is I've got another one. In my experience, that's the one unhappy person that I've had, um, like 10 years ago. So I think that is a big um, point, that you've got to get something that fits your frame. It fits the width of your frame, the dimensions are right. If you get it right, and when we look at implants, we're looking at the width, we're looking at the profile, we're looking at the shape of the implants, and it's the shape that you've got to get right that fits your frame. And if you get that right, then that is the right implant for you. And often people say, I wish I'd gone bigger. And you're like, well, that fitted your frame, you'd have had to go wider or fuller, and it might not have fitted your frame quite so well. So it's got a very high patient satisfaction, but that's the one. The other one patient I've had, she was very good about it all, but she had pain. She had persistent pain, and I removed the implants. So whether she regretted it, I don't know. But that was upsetting as well. That was not that long ago. That was a few years ago. But by and large, that's out of the hundreds of people who have breast implants. People with there was a thing recently, wasn't there, about a breast implant illness, people getting ill, rheumatoid arthritis, diseases, and all that sort of thing from the implants. But I've never seen it, and I'm sure there are people out there who've had surgery and who have regretted it, and no doubt they're very vocal on the internet and what have you. But it's not something having see people all day every day who've had implants. It's not something that I see, but it's a thing. So I'm not saying it never happens. I'm just saying, if you ask me specifically, those are the two people in the last 10, 15 years that I can remember who well, I don't know if the lady with the pain regretted it because she didn't know she was going to get pain, but I do think the other one did regret it. And she went on to have smaller implants and teardrop implants and things like that. Debbie, look at that. She's rise to the challenge. Now, first of all, Terry, what's going on there? Is that a monkey saying see no evil? What's going on there? Don't understand that one, but nice to see you, Terry. Debbie's back in with a question. I set her a challenge and she's back. Is there a point which is too old for a tummy tuck due to this? No. As I say, tummy tuck's good when the skin, well, it's difficult when your skin elasticity when your skin's more elastic, you're going to get a lesser result because your skin's still going to be still inelastic, but it'll be easier to do the surgery and easier to get a lower scar. The age thing, and the age thing for any sort of surgery really is really about your health. So if you're 60, 70 and you're in good health and you've got a problem that can be fixed with surgery, and you can weigh up the risks of the surgery compared to the benefits you're going to get from the surgery, then you make a balanced decision, whether you're 70 or whether you're 40, to be honest with you. You make a balanced decision on the risks of surgery versus the benefits it's going to give you. And if the risks are high and the benefits are low, it might not be worth having it. But you know, the risks are higher in an older person, and they're going to enjoy it for less time. But I've done quite big operations on breast reconstruction on people who are 70s and things like that. So it's not really, we don't judge on an age thing anymore. I think people do think there's an age cutoff, but there isn't. It's on health and fitness. Sometimes you can have a 50-year-old who's not very good condition, who's not very healthy, who smokes, who's overweight, who might not be a good candidate for surgery. And we'll say, look, you're not really a good candidate for surgery. You might have a fit 70-year-old who would benefit greatly from the surgery, who accepts all the risks, and we'll take it on. So no, there's not a point at which you're too old for a tummy tuck. Certainly not due to the skin elasticity. It'll be easier in a way, but you won't get quite as good a result. It's like when you're doing a mastopexy on people who have had many, many children or have lost a lot of weight. The skin's been stretched a lot. It's not going to be able to hold the breast as tight as someone who's got better skin elasticity. So you're absolutely right. The better your skin elasticity, the better result you're going to get. Notwithstanding the comment earlier about the scar, about the high scar thing, but you're going to get a better result because it's going to be tight as a drum, which is what you want. God, this is confusing, all this, isn't it? Gosh, what an algorithm. Oh, slouching. Oh. Get the pillow there. Kick back. Right. I'm not sure if this was a Facebook Live question, but anyway, I'm going to show it on screen. I'm not sure if this was just a question that someone was asking. Get the mic. Oh. Can I talk to another patient who has had a BBA? Yes. Yes, you can. Yeah, absolutely. We'll talk to a previous patient who's had surgery. We do that all the time. And this is a patient who's been to clinic, but just in general terms for people out there, I think most doctors would be happy for you to talk to a previous patient of theirs. And I think if you want to, then you can ask. We try and actively offer it. And once you get into offering it, then if you speak to someone who's had it done, then when you've had it done, you might be more open to speaking to someone who's thinking of having it done, if that makes sense. So it becomes a self-fulfilling thing, because once you get people who've had it, they're happy to help others in their situation, in the situation they were in before. I think that's clear. Bit like the forum, we've got a Facebook forum, a closed forum for people who've been to the clinic to share experiences, because I think it's good to talk to people who've had it done and been through it all. Real people, because we can say, oh yeah, you mustn't do exercise for 4 weeks, but if you speak to a real person, it might be better. Can I bring other clothes with me to try on with sizes? Yes, you can most certainly do that, and that's something, again, we encourage you to do it. sorry, but I have to say, I'm not sure. Excuse me, sorry. That's a bit awkward, isn't it? Live TV. Oh dear. I have to say, I think it's good to get an idea of how you're going to look, because you want to get an idea how you're going to look in clothes. A lot of people think, oh my God, I'm going to have to get a new wardrobe. Or I'm having my breast done, so I'm going to have to get a new, I'm a size, I don't know, whatever number, and I'm going to be another size number. The fact of the matter is, you're not. You're probably not, because probably what you're doing now is you're wearing a padded bra. And when you have surgery, you'll probably look similar to how you look now with a padded bra, but you won't be wearing a padded bra. So probably your clothes won't really fit that much different if you're wearing a padded bra now. People are often surprised, thinking, "Oh, jacket fits." You're like, "Yeah, but but please do bring your clothes and bring different outfits and do anything. That's absolutely do that." So yes, you can do that, but it's often not as helpful as you think, because actually, when you're wearing clothes, you're wearing a padded bra, and so you will look similar to how you look now. Unless you don't wear padding in your bra now, but most people do. And so it's really the look sort of out of clothes that's going to be different. And it's how you feel about yourself, because you won't have padding in the moment, and bikinis and things like that, where it's sort of less easy to have the padding. So that's really where it comes in. And it's actually how you feel about yourself, because you're not got a padded bra anymore and you feel better about yourself. And a lot of this is about yourself. A lot of people say, oh, no one's noticed. We've had to pay all this money. No one's noticed. Well, often no one does notice, because you were wearing a padded bra before, but you're not now. So, yeah, so definitely you can bring clothes. How long to wear compression for? I've been wearing a compression garment and binder for 4 weeks now, and was wondering how long you recommend wearing both for. Can you talk about the benefits of wearing them and length of time recommended, etc.? P.S. TT with MR and lipo. Now I know what all that means now. That's a tummy tuck with muscle repair, MR, and liposuction. Yeah, obviously, know that one. She said 6 weeks in brackets torture, but others are saying 3 weeks from same surgeon. You need to try and design a better one. There's a lot of money being made from these binders and compression garments, and no one makes a decent one. You know what? I'm on it. I'm on it with the bras. I'm on it with the bras. But fair warn. You know what I should do? Just had an idea. I've just had an idea. Fair warn, I am on it with the bras. What do you think of this? I've just had a great idea. Oh my God, it's just come to me. This. This is going to work. So, yeah, we're trying to look at that. Oh, so what's going on? Last question, fair warm. Last question. So this is the last question. So yeah, we're trying to look at bras, different types of bras, but this again very much surgeon dependent. Very much surgeon dependent. What do you think about that? Is that a good thing to do, that last question thing, or is it a bit silly? Anyway, I'm going to be honest with you. Sometimes it's good to be set with patients and say, you've got to wear the binder for 4 weeks or whatever. What she's been told, 6 weeks? Yes, 6 weeks. You've got to wear the binder for 6 weeks. And you've got to do that. And people like that. And they're comfortable with that. When you look at the facts of it, when you look at it scientifically, at the evidence for stuff, you'll find, particularly in this sort of thing, the evidence is not great. Now, when we do a certain type of breast reconstruction, we take some tissue from the tummy, we tunnel it up to the breast, and we don't put any compression on the tummy because the blood supply is still there in the tummy. So we don't use a binder, and they've had the equivalent of a tummy tuck. We don't use a binder at all, and they're fine. So I'm sorry to say, you don't have to use a binder. There are people out there who don't use binders. Now, whatever you do, go with your surgeon, right? So if your surgeon's saying this, you better do what your surgeon says, because they're the ones who have done your surgery and they've got their post-op regime. So they'll be a bit annoyed if they say, bloke on the internet last night said I don't need a binder. But the fact of the matter is, there are pros and cons with anything. There are cons with a binder. They're uncomfortable. They reduce the venous drainage for your legs. You're increasing your risk of DVTs and things like that because they're pressing on your tummy. So there are bad things about a binder. There are good things too. They help the swelling, and then sometimes people like them. Sometimes people find them comfortable. I normally wear them 4 weeks. Sometimes people want to wear them for longer. But there are pros and cons, and I'm sorry to say it's not written in stone. And I don't know. I don't know what the answer is. I am a bit more with patients, a bit more like, well, pros and cons, see how you go. And if it's uncomfortable, you don't have to wear it. But sometimes I think patients like it. If you say, look, you've got to wear this for 4 weeks because it's going to give you the best result. And then psychologically, they're engaged, their treatment, and they feel like they're doing the right thing. And it's not helpful if someone says, yeah, whatever, doesn't matter if you don't wear it. Yeah, see how you go. And I think, but the fact of the matter is, it's a tricky one with binders. And there are some well-respected surgeons out there who don't use abdominal binders after a tummy tuck because they can cause problems and they don't feel that they need them. I do use a binder. I do think it's supportive. I do think it's nice to have a little bit of compression. You worry about seromas and swellings and things like that. So I do think it helps. But if it digs in, if it hurts and all that sort of stuff, I say, look, don't wear it. If you want to wear big pants instead, if you've got some big pants of your own that are comfortable, those sort of contouring pants, wear those instead. Just some kind of support I think is helpful in the first few weeks. I normally say 4 weeks, but end of the day, do what your surgeon says. But if you're asking for, it's not written in stone. Basically, it's not written in stone. Everyone's different. And if you're finding it torture, especially, what I don't want is people coming back with red marks. I've had people who've had like ulceration and red marks and all sorts of problems with the binder. And that's really not the point of the binder. You really don't want to have that. So it's got to be comfortable and it's got to be helping you. All this is helping you and helping your symptoms. You won't find good evidence to say that you're going to get a better result by wearing the binder for a certain period of time. They've never done that sort of randomized controlled trial where they've taken, randomly half the patients and given them a binder, the other half and not given binder and say, look, these guys with the binder have got a better result. That this trial doesn't exist. So you've got to feel comfortable with it. But at the end of the day, I think this stuff, you've got to sit with your surgeon and don't do what I said because I'm not your surgeon and I'm just trying to give you a bit of, trying to put my bit out there and give you a bit of info. So yeah, got a bit animated on that one. Okay, so that's the questions there for tonight. I hope that's been helpful. Debbie, you get the gold star for asking the most questions, so thank you very much for that. But notwithstanding all the other fantastic ones, Fiona, Sonia came in with a blinder. Gemma got in early before it started. Now that's classy. Before it started, people take a leaf out of Gemma, my friends. Get in there before it even started. Oh my God, Debbie's got in. What? Debbie, the last question. Sign. Hold on, I've got to get that thing off. Well done with your last question, Sign. You looked very pleased with yourself. Yeah, I think you know what, Debbie? I saw the viewers drop when I put that last question sign up, so I thought that was not. I thought it was good, Debbie, but I got a number of you and it just dropped. So I thought, seemed like a good idea at the time. But anyway, hey ho, you got to try these things, always trying new things. And maybe I'll just do that instead. But anyway, gotta work at that. So that's the thing for tonight. And I am gonna, before I lose anyone else, I'm gonna go myself. Have a great evening, everybody, and thank you all for coming and for I've got that one as well. For contributing and for watching. And Khan's still here. Are you still here, or if you've come and gone? Good to see you. Thank you. And I am going to check out. And next week, same time, please ask questions. Feel free to get in there early, like Gemma did. That was excellent. Or email us, or Facebook us, or do whatever you want. Come to the clinic and ask them. But please ask questions because I'd love to go through your questions with you this time next week. I will see you then. Bye.